actually going to change the disease course. It's very difficult to say whether the wall is really thickened or is just a different angle of measurement. But we have been trying our best. He has been well, and there was clear response in his concentration, in his general well-being. Twice the treatment was tried to be tapered. Once he himself did, and once we tried. But on both occasions, he had a flare-up of his symptoms and worsening of his clinical condition. Currently, he is taking azathioprine 100 milligram a day and diltiazem of slow release to 40 milligram a day. He is very well settled. He has done a senior managerial job in one of the company. He's married and is very happy, except that he's got slightly sparse hairs on his scalp. But he's not worried about it because his wife has well accepted him. So this is what Takayasu arthritis is. Chronic vasculitis of the aorta and his main branches. Less common, can involve pulmonary and coronary arteries. It's common in young women, unlike this young man. We see young women as well. This was my first case in Pakistan, so I presented that. But certainly it's much commoner in young women of Asian descent, and is seldom seen after the age of 40. This is the ACR criteria, that age should be 40 at disease onset. Claudication of the extremities, number 2. Number 3, decrease brachial artery pulse. And number 4, blood pressure difference between the two arms greater than 10 millimeters of mercury, bruit over subclavian artery or aorta, and aortogram abnormalities showing occlusion or narrowing. At least 3 out of 6 should be present to make a firm diagnosis of Takayasu arthritis. There is a pre-pulseless phase where the patient can complain for some time of malaise, arthralgia. They may have synovitis, generalized weakness, and low-grade fever. But when the pulseless stage comes, then these symptoms of claudication, headache, dizziness, diplopia, renovascular hypertension, cardiac involvement may lead to chest pain, palpitation, and dyspnea, hemoptysis. All these should be kept. We should keep a high vigilance for these symptoms to develop over the course of time. Laboratory findings are really minimum. ESR is something what we monitor, what we can monitor, but how much to trust ESR as actually the disease predictor of remission or activity is really not certain. But to a certain extent, we combine ESR with other clinical features to give us a rough idea of what to do with our therapy. As I said, arteriogram can show all these changes. There is no specific lab test, and tissue is rarely available. These are the pictures, not from this patient, from some other patient, showing narrowing and post-stenotic dilatation of the main branches of the aorta. The arrows are showing that. Right, so what treatment did we give? What do we normally give? Steroid, as I mentioned. Methotrexate can be used as steroid-sparing agent. We should manage the hypertension, and sometimes when the stenosis is too much, percutaneous transluminal angioplasty or even surgery can be required, but that's somewhat uncommon. Coming to the other giant cell arthritis, the other spectrum, the other spectrum of the age, and polymyalgia rheumatica, they're possibly opposite end of clinical spectrum. A PMR may be form firstly of giant cell arthritis in a subset. I'll mainly talk about giant cell arthritis. Age always above 50, women more often than men. Prevalence high in Scandinavian countries and very rare in blacks and Hispanics. This is the common involvement of the vasculature, thoracic aorta, and major branches. The carotid artery, extracranial branches, temporal, occipital, ophthalmic, and posterior ciliary, and subclavian and axillary. This is showing some necrotizing infiltrative process with necrosis, and this is the giant cell. You can see multinucleated cell in the center. Not seen in all cases of giant cell arthritis. Almost 50% of the patient can show this pathological feature. The general features, other general features include involvement females 70% gradual, 64% gradual onset weight loss in 50% malaise, 40% fever in 42, and PMR-like symptoms in 39% of patients. The local features include headache seen in 68%, they're quite severe and localized. Scalp tenderness again seen in almost two-thirds of patients. There may be thickening, irregularity, sometimes tortuosity, or even nodularity of temporal vessels. There could be ischemic optic neuropathy. This is an emergency and should treat this patient very seriously, and high-dose steroids should be given. If possible, we can give actually as a pulse, either intramuscular or IV, depending upon the situation. But ischemic optic neuropathy is an emergency. Jaw claudication can be seen in 50% and cyanoid in 15% of cases. 10 to 15% of patients of large vessels, giant cell have got aortitis, and we should keep a high vigilance for that as well. Raynaud's phenomena, aortic aneurysm, aortic insufficiency, PMR-like features can be associated with aortitis. Again, the ACR classification criteria of giant cell arteritis: age should be greater than 50 at disease onset, new headaches, temporal artery abnormalities, tenderness or decreased pulses, elevated ESR greater than 50, and abnormal temporal artery biopsy with mononuclear cell infiltrate, granulomatous inflammation, usually with multinucleated giant cells. There should be at least 3 out of these 5 criteria. This is critical ischemia showing cotton wool spots, and this is the stage we should not miss and give treatment, because when optic atrophy develops, it is irreversible. Thoracic aortic aneurysm on the CT scan, the arrow showing the aneurysm, and also aortic dissection on these pathological specimen. All these are uncommon but should be vigilantly sought for. These are the tortuous temporal vessels, irregular, and they are tender. So, issue about temporal artery biopsy: we should biopsy the abnormal site. 4 to 6 centimeter long specimen should be taken if there is no obvious abnormality in the vessel. If there is strong suspicion and one side biopsy is normal, then other side biopsy can be thought of if there is a very strong suspicion, and Dopplers can be a guide to taking the biopsy. The treatment is the corticosteroid is the mainstay, usually high dose 60 milligram a day or 1 mg per kg.